Good evening, everyone. My name is Sharon Moreno, and I'm a family nurse practitioner. I practice telemedicine via this great state of Texas, and I see patients physically in the Rio Grande Valley. We are Gold Rush Health Solutions, and this is Let's Talk Health. Today, we have a great topic, actually, a very interesting one. We're going to talk about hospice today, and I have a special guest, actually, a few guests associated with our Caring Hands hospice and palliative care. So I'd like to introduce them, or actually have them introduce themselves. We have Isabel and we have Miguel. Say hi, guys. Introduce yourselves to our public.
Hello, everyone. My name is Isabel Medeles, RN, and we're with our Caring Hands Hospice and Palliative Care. We are located at 3420 Carmen Avenue in Rancho Viejo, as you see on the screen, possibly. Our phone number is 956-280-5339. Our Caring Hands Hospice and Palliative Care has been around for about 7 to 8 years, going on 8 years now. And I have been a nurse for 24 years, and I've been doing hospice for 17 years. Yes, so most of my years is hospice, yes, and I love it. And yes, I'll allow the next person to introduce themselves.
Miguel.
Good afternoon, guys. My name is Miguel Ruiz. I'm a hospice nurse. I've been a hospice nurse for the last 14 years this year. Do everything from management and, office work, but my passion is bedside care. So work with great team with our Caring Hands, and we're here to talk about hospice, a very touchy theme sometimes, but hey, we're here to dispel any doubts.
Absolutely.
Absolutely. It's a topic that's near and dear to a lot of our hearts. I'm sure that everyone has had at least a friend or family member that's either had hospice or have thought about hospice and really haven't known how to navigate this particular topic. So this is a great time to ask questions. I do have a disclaimer, and my disclaimer is I actually work for our Caring Hands. So Isabel is my boss. So I am on my best behavior. I am on my best behavior tonight, I swear. We have our first comment here, and it's Christina. She's saying, hello, Sharon. So, hi, Christina. How are you? I'm so happy to have you back. I had been missing you for a couple of shows. So, thank you for showing up tonight. We have two special guests regarding hospice. I know this is a topic that's near and dear to your heart. So, please give us whatever feedback or questions you have for us, okay? All right, so we always start with our legal disclaimer. I'll place that up. In the meantime, we kind of get started. In the meantime, I let Isabel and Miguel take a deep breath and get their thoughts together. Um, Again, as always, whatever topics you guys are interested in, I'd like for you to post those topics. Serving the community, giving medical information is extremely important to me. So if there's a particular, whether it's a medical topic, a medical service that you're interested in learning about or knowing more about, please post those in your comments, and we're happy to cater to you. Uh, Again, let us be your resource for your community, whether it be myself. 956-640-6963 is my cell phone number. Text me for any medical questions, comments, or concerns that you have. I offer a variety of services. If you have hospice related questions, comments, concerns, please let our Caring Hands be a resource to you. 956-280-5339. And I have another comment here from Jeannie. She says, hi, Sharon. Hi, Jeannie. How are you? Thank you again for showing up for tonight's show. So let's get started, guys. Let's give a brief interview about hospice in general. Tell us, what's hospice? What's hospice? What does this mean?
Hospice care is basically a service that for our families, for our patients who are dealing with chronic diseases, end of life diseases. And we are here for the families. It provides comfort measures for the terminally ill. And when we say terminally ill, we're dealing of those chronic illnesses that the physician or the doctors are saying that there's not a cure, or that the family members or patients are no longer wanting to seek those curative treatments. And so
Sure.
basically, overall, that's what hospice is, the hospice care. Yes. And it
I
deals with
agree. What
hospice.
can you add? What can you add to that, Miguel?
Well, the way I talk to my families is, first of all, hospice is like specialized care for patients that are facing life-ending illnesses. Now, our focus is for comfort, dignity, quality of life at home, or any other any place that we can provide the service. One
Sure.
important thing is we have a whole team. We have nurses, but we have our medical director, we have our nurse practitioners, we have our nurses, our social workers, our chaplains, our CNAs. We have volunteers, and we all work together to provide that comfort care, that symptom management, that end of life treatment that we can have for our patients. So, like I mentioned, it can be at home, it can be a nursing home, it can be nursing facilities, comfort homes, and we also do hospice care in hospital. And
Sure.
in my thinking, it's not only a service; it's a philosophy where we respect our patients' wishes, where we ease the suffering not only of our patients but of the families, and
Absolutely.
then we respect the wishes and find peace through this very, very difficult time.
Absolutely. I think that's well said. So there's a big myth out there that's pretty common that once a patient's in hospice, that they're stopped, all treatments are stopped. So
Mhm.
all the medications are removed, feedings are removed. That basically patients are left to die. What do you say when family members say, "Hey, I hear that I'm getting into hospice and they're basically coming here to be killed"? What are your responses to those kind of myths?
Yes, no, absolutely not. So first we need to listen to the family and to the patients on what the situation is, of course. No, we do not speed up the process or stop the process from happening. We respect the natural ways of the disease progression. And so, no, we continue with, let's say the patient has a urinary tract infection, a UTI is what they call it. And so, no, absolutely. The doctor will order antibiotics, or if he asks, no, get a UACNS, or as you have ordered, get a
Yes.
UACNS, we get those things. Absolutely. They have a cough, they have congestion, they need an x ray. Absolutely, we'll get that x ray. Uh,
Yep.
the quality of life is we want to make sure that the patient is getting everything that they're able to receive within the home or wherever they're at. Like Miguel said, we go wherever the patient is. And so providing them with that dignity, that respect that they deserve. Absolutely. No, we don't. And that is a very large misconception that hospice is for end of life, the last day. Absolutely. This is a wonderful benefit that Medicare, Medicaid covers 100%. And so a lot of people don't understand that. And so it is to provide the care within the home or wherever they're at, sending nurses, sending CNAs, if allowed, um, the social workers, the chaplains, providing that care so they can have that emotional support, spiritual support, symptom control at home, and with pain
Absolutely.
management if they have pain. Absolutely. No, we provide that care at home. Absolutely.
And I
Hmm.
am 100% a witness of that because I
Yes.
give plenty of treatments. I give plenty of antibiotics. We order x-rays. We do a lot of different of treatments for patients. So nothing is being stopped. It's a multidisciplinary approach where the family member and or the patient or the captain of the ship, and we simply give guidance. I have a couple of comments here from a couple of people. So Christina says, "Thank you, Sharon, for taking care of my family member when they were on hospice. You all are angels." Absolutely. Again, if people have had loved ones that have used the service, they absolutely know how important these services are. They make a big difference in people's quality of life. And Norma saying hi to everyone. Hi, Norma. How are you? She's a faithful listener of ours. She's on the majority of our shows. I have another faithful listener, B. She says, "Hi, Sharon, a great MP." So, again, a lot of these particular individuals have had experiences with hospice themselves. So, I've asked them to share whatever experiences they feel comfortable sharing. So, I'm hoping that they ultimately will, so that they can help other people make decisions as far as quality of life for their family members.
One of the big misconceptions, or one of the big things that I always try to instill in my families when we go see them, is that a lot of times medical professionals don't have the tact, don't have the, I won't say compassion, because we all have compassion, but the way that
Sure.
hospice has trained us, that one of the worst things that I hear is whenever somebody says there's nothing else to do, or they brought my mom onto hospice, they brought my dad onto hospice because there's nothing else to do. There's always something to do. We can always control the pain, we can always control the anxiety, we can always provide comfort, and not necessarily
You're right.
medically, but also socially, spiritually. you know
Spiritually, sure.
so a lot of hospice, especially here with our culture, it's such a big taboo, because like you said, they think hospice
Yes.
is end of life, and yes, it's end of life care. But one thing that I tell my families is that hospice is a blessing, because we have the chance to say goodbye in our own good terms. How many
Mhm.
times you hear that? Oh, did you hear so and so crashed? Oh, I should have told them, I could have said this. You have the chance, you know and I've personally experienced hospice with my father-in-law, with my godmother and my godfather. And when I have the talk with the families, I know what I'm talking, because I had the same talk with my wife, with my dad, with my mom. So it is truly a blessing. It is a blessing, and it's something that needs to be brought up. And thank you, Sharon, for sharing this, because it's something that needs to be brought up
Yes.
more.
To our community.
Yeah.
Absolutely. It's
Absolutely. That's why we're doing this.
a blessing. Absolutely.
That's why we're doing this. It's really important. So, kind of piggybacking on what you mentioned, Miguel. So, I'm a girl of statistics. I love statistics. So, I dug out a couple of statistics regarding hospice, and one of them is about quality of life and longevity of life. So, the first piece of information I got here was that hospice has been linked to longer longevity, meaning that patients are living an average across the board of diagnosis. Some diagnosis more, others diagnosis less, but on average, 29 more days longer if they're in hospice services versus not being in hospice services. So some people think, you know what, if I'm getting seeking aggressive treatments, versus meaning like chemotherapy, if I'm getting, liquid drain from my lungs, from my stomach, if I'm doing all this aggressive treatment, well, clearly that means I'm going to live longer, right? But the answer is no. When we place our body under a lot of stress, that can really lower lower immune system. We're in the hospital, we're doing these procedures. Our immune system is low. Now we're around other people who are very sick. So we can get very sick then and then pass away unexpectedly. So 29 days, that's almost a whole month. So just saying, you know what, I'm going to sign up into hospice services. I'm going to stop all the aggressive treatment. I just want to be here at home, comfortable around my family members. Statistics shows it gives you an extra 29 days. And not
Yes.
only are you alive 29 days, but they're a comfortable with quality 29 days. That is significant to me.
Absolutely. I agree with you 100%. And also, if they have questions about, do I give the pain medication? Oh, I'm going to give the pain medication and they're going to get worse. No, they're not going to get worse. They're going to sense relief, which in turn, as your statistics show, will we don't want to prolong, we don't want to speed up or prolong the situation, but your statistics prove that they're comfortable and they live a little bit longer, with those
Absolutely. And what people need to understand is the
with that
medications we're
management
giving
of
are in
symptoms. Absolutely.
prescribed doses. We're not giving any doses. We're
Absolutely.
not giving anything that's out of prescription doses. So we're not killing anyone with morphine. Whatever, I've
Absolutely.
said, oh, I don't want to, no, no, but you guys are killing people because you're just giving morphine and killing people. But no, these are
No.
prescribed doses. People are having, respiratory distress where they're breathing very quickly. Their quality of breathing is very poor. And so we give a prescribed dose of morphine that's therapeutic for that particular issue. The breathing now starts to become less rapid and so more effective, so they become less symptomatic and more comfortable. So no one is
Yes.
giving them a whole bottle of morphine for them to down to say, okay, get them out of their misery and they're gone. That is absolutely not how hospice works.
And I
No.
think we
And
can talk
absolutely.
about, later on we can break it down with the comfort kit, the medications that we have.
Yes,
That way we can
yes,
go through one by one, explain the action, explain the use. Um,
Yes.
that way we can,
And
because
respecting their wishes, as you say. And if they don't want to give the medication, we completely respect that. Because at the end of the day, like you
yes.
said, they're the captain. So we're here to explain the benefits and the risks. And at the end of the day, we respect whatever they decide. It's like you mentioned,
Absolutely.
having that compassion. And when you have compassion, there's no judgment. If there's judgment, then it's not compassion.
I
So that's
like that.
I heard that
I
this
like
past
it.
Sunday and it hit home. I said, that is a message I'm going to share. Yes. So if there
I
is
like it.
judgment, no compassion. Yes.
I like that.
So we respect whatever the family decides. And if they
We have
have any, oh, go ahead.
We have two comments. We have a good evening from Renee. Good evening, Renee. Thank you for showing up. He's been on the last couple of shows, so that's good. Hospice care is important. And B says, yes, it's a great blessing. She's referring to hospice. I was able to spend 5 beautiful years since we were told she had cancer. So this is kind of one of those testimonies that's hospice related. So a lot of great things, a lot of great outcomes with hospice. And I'm the kind of provider, I'm not speaking for other providers, but I'll speak for myself. I will sit there and do extended visits. I'll massage patients' legs, feet, sit there and talk to them and spend time with them just because these are little things that make a big difference with them. And those are quality and meaningful things. And you can't get that in a doctor's office or getting an MRI. It's kind of like a production line. Hurry, hurry, hurry. And in hospice, we have that time with those patients.
That's what I love the most. Absolutely. And so even with the, let's say, patients that are unable to communicate and the caregivers are 24 hours, they look forward to our visits because I call it, we're having adult conversations. And so we're able to talk to them and, in a respectful way, professional way, but they look forward to
Sure.
our visits for that reason, because we can relate, we can talk to them about whatever they're going through, whatever they're feeling, even if it's not hospice related. We're there to make that connection.
Absolutely.
Yes.
Yes.
And I always tell my families as well, if they have any hesitation regarding our service, just try it, and in the event that they're not satisfied, they can always stop the service, right? But of course, we don't get that because they love our service and they know it's beneficial
Absolutely.
to their loved ones and them. Yes.
I agree.
Yes.
So let's talk about some of the diagnoses that we see most commonly. What are the kind of patients that we see coming into hospice?
Oh, broad spectrum. We have from severe protein-calorie malnutrition, end-stage heart failure, cancers, a peripheral vascular disease, end-stage renal
Alzheimer's.
disease. They no longer
Alzheimer's, dementia. Those are the.
Alzheimer's.
Yeah.
Yes,
So statistics
absolutely.
list five different ones, and they say that the leading diagnosis for hospice is actually dementia. It's a quiet, tough diagnosis. That's a difficult. We spoke about that one. We had a show about dementia some time ago. But that's the leading one. Respiratory illnesses is number two, like COPD,
Yes,
smokers. The third one are heart diseases like congestive heart failure, ischemic cardiomyopathy. The fourth one is stroke. And then the last one is cancer. So that's normally what we see. But we see other things like Parkinson's disease, as you mentioned, Isabel, severe protein calorie malnutrition, where people just aren't eating like they should. So they're very thin. So there's a variety of things. If you're unsure, it doesn't hurt to get an evaluation. I've seen many patients where we go and I'm like, nope, they're not quite there yet. But let's see you in 3 months. Let's see you in 6 months. And, then we get them on board later on. But it never hurts to call us and say, hey, I'm not sure. Can you help us or not?
And sometimes the way we
exactly.
get the referrals is by the family members that they're burnt out. A lot of times they're
Yes.
burnt out. I don't know what to do with mom. I don't know what to do with dad. He's not eating. She's not eating. She got lost the other day, and I think one of the biggest drawbacks that we have with our community is that they think hospice is that's it, and we've shown it many times that they can have a better, more comfortable, better quality of life when they're with us, when they're with a program, than trying to deal it by yourself.
I
I
agree.
personally had that. I personally, when I was in Mexico, I was 7. My grandma used to live with us, and she lived with us for about 4 years, and she had Alzheimer's dementia. And over there, there's no help. And I remember my mom, trying to change her. I would literally carry her from her little rocking chair to the bed. And I would remember my mom being mad, but now I understand that she didn't get mad at my grandma. She got mad at the situation. She was
Yes.
because there's no support, and that's one of the biggest things that you should see the face how their face lights up when one of our CNAs walks in, when one of our nurses walk
Oh,
in,
yes.
and like Isabel says, sometimes that little hour that we're there is such a big respite for not only for the patient but for the family, that they say, you know what, I'm gonna go take a shower, I'm gonna go for a coffee, I'm gonna go for a drive, because they know that they're in good hands.
I agree. I agree. And we have excellent, excellent aides, second to none. Those ladies work extremely hard. I mean, those patients are squeaky clean they've exited the patient homes. And sometimes, like you mentioned, even the family members will stay there and just chat with the aide. It's kind of like a little outlet for them. They're venting and, so they serve more than one purpose.
I think it'll be a good time to talk about the team. Do you think, Sharon? Who
I
who
think it's a
comprises?
great, yes. Yes, absolutely.
Yeah, the
We use a
team.
So
multidisciplinary approach.
we start with a medical director. Medical director is the medical director that oversees the program. And I Miss Isabel, you want to talk about what a medical director does and how we get our patients from a
Yes.
medical director?
So initially, so the patients can come from anywhere. The patients can come from the family members calling us and giving us the information so we can go evaluate the patient. And we request medical records. And if we don't have medical records, we send Miss Sharon out to go and evaluate, the patient. So once we've gotten that information, the physician reviews the whole case. And so they want to make sure that it's appropriate that they are in stage for these diagnoses. And so he also guides our team on that care. So we have a meeting, which is called the IDT meeting, interdisciplinary team. And so he guides us on reviewing all of the patients, and we let him know, how the patient is. And so after every visit, the physician is aware of what's going on with the patient. So we update him that often, and also Miss Sharon as well. In the
Yes.
event that something's going on, and we see something different, we report it immediately to them, and then that way they can guide us on, what is it that we move forward with. So that is what the physician does overall, and he oversees overall our QAPI, which is our overall infections, our overall incidents, falls, things of that aspect as well. Yes, he's the one that oversees that. And the next would be our social worker. Social worker oversees the psychosocial support and community resources. So let's say in the event they don't have provider services. And so she can assist with that. If they qualify, what other service they qualify for, what other services or benefits that they may, be able to receive. And then our chaplain counselor oversees our emotional, spiritual support. So not necessarily, some patients, some families don't want to speak about anything spiritual, but that's okay. We respect whatever they wish. And so they talk about emotional support. Hey, how have you been? Or, just spending that quality time companionship with them. And then we have our hospice aides that go assist in the bathing or the range of motion exercises. We have physical therapy, occupational therapy, and speech therapy. Those are disciplines that can assist in giving us exercise programs that we can do within the home, if for comfort measures only, of course. And we have a dietitian as well. If we see that they are in need of any specific diet, or we see that they're having any issues with swallowing and so forth, is it part of the disease process, or is it something that they need to, give orders on? But of course, we have our experts as well. Sharon can do that as well as our hospice medical directors as well. So that is overall our team. So it's the physician, the nurses, our nurse practitioner, the social worker, the CNAs, and PT, OT, ST, and dietitian. So that's our
And our
overall team.
volunteers. And volunteers.
And our volunteers. Yes, absolutely. We're always looking for volunteers. So if you
Yes.
want to volunteer, you call us and we will definitely, each volunteer is treated as an employee. And so they feel everything as an employee. So that way they have to go through the process, because we need to make sure they're clear to see patients if they're willing to see patients, or an admin, so they can help within the office. So yes, absolutely. We're always looking for volunteers, or those disciplines that are going through school and needing to put those hours in for social worker, or, other disciplines that they need to put hours in. Yes, we're here,
Students.
to help that.
And
As
if
well.
anybody has
Yes, the
kids
students.
that are getting extra credits, or want to look good on their resume for college, it's a good thing.
Absolutely.
Yes, we do. Well, absolutely. We send them out. If we have patients within the nursing home, they can go assist with the loteria or with some sort of bingo in that facility, or go see
Sure.
patients, to read them a book or anything of that nature. Yes.
Yeah, patients love company, sit with
Absolutely.
them and chat with them and stuff. A lot of times they don't really care much about my visit, but if I sit and I talk to them, they'll be like, "You're leaving me here already?" I said, "No, Mama, I'll stay with you a little bit longer." And we just talk about, I don't even know what, just random things. It could be news, it could be weather, just random things. They really like just the chat. So a lot of these people are lonely. They don't have a lot of family
Yes.
members that take the time to sit with them and stuff. So, they
You
really
know,
appreciate our time there.
a lot of times when I used to train nurses, um, and I would tell them that we before we get in the vehicle, before we get in the house, we get to the house, and I tell them, look, write me down anything that's bothering you right here. So they'll write, whatever. The kids didn't wake up in time, the truck didn't have gas, whatever it is. I would tell them, put this right here. We're gonna put it in the little cup holder. Nothing that is bothering you, nothing that is going on with you is worse than what can be going inside that house. And sometimes we're the only face the outside face that they see.
That's true. Very
So
true.
I would tell my nurses, leave everything that's bothering you, anything, and you're not gonna get anything that's worse that's going on inside. Nothing can happen to you right now or is bothering you right now that's going what's going on. So you need to walk in with a fresh face, with a good demeanor, with a good attitude, because those people are depending on that. It's not only the medical, it's not only the knowledge that we have, the treatment, it's also how how those patients perceive us, because we do more than just bedside. We're there to help the families also, the caregivers that are burnt out, the caregivers that they're only there trying to manage symptoms and they don't even know what's going on outside. Sometimes we go in and wow, it's raining. It's raining. Like, yeah. And that's one of the things that we have to understand, that as clinicians, that we're there for everybody, for the whole family.
I think those are good points. Um, let's discuss a little bit about the comfort pack. So a lot of these symptoms that we could get with the patients include things like nausea, vomiting, pain, dizziness, constipation. And so us in hospice tend to be proactive and state, okay, these are the things that happen most commonly. And so when the patient comes on board, then we give them what's known as a comfort pack that includes a variety of medications to help somewhat alleviate these sort of issues. And so they're going to speak regarding what's in this particular goodie bag, if you will.
So our
Yeah.
comfort kit
So
includes a
this,
lot of medications. It has, well, first of all, morphine. And morphine is very taboo in the community. Everybody hears morphine, and it's one of the worst things. And like I tell my families, I'd rather have it in the house and not need it than, personally speaking, I'm one of the nurses that's on call, than getting a call at 2 in the morning and you don't have the medication. So I tell my families, I'd rather have it and not need it than need it and not have it. So we have the morphine. Morphine not only helps with pain. Everybody thinks morphine and pain, but also, like Miss Sharon was saying, it helps with that air hunger. It helps your body kind of slow down a little bit and breathe in a little bit better. I always tell my families that back in the day when somebody was get agitated, they would put a paper bag. So that triggers something in your brain that says, I'm breathing in some gases that I don't need to breathe in, so I'm going to slow down. So morphine kind of helps with that air hunger by, yes, you're going to breathe a little bit slower, but you're going to breathe in a little bit deeper, and it's going to help with that air hunger. We also have something called lorazepam, alprazolam, lorazepam. It's something to kind of help. I tell my families, morphine, think about it, that is going to help your body. Lorazepam is going to help your mind. So lorazepam is for that anxiety. A lot of our families, we have, or patients, we have terminal anxiety. It's the body's decompensating. The body's going through this process that the body doesn't know what's going on. So by giving that medication, it kind of helps you relax a little bit. It kind of helps you process that, all of that, a little bit better. Now, like Ms. Sharon was saying, we also have the Bisacodil, which is a constipation medication, because with the opioids, we do have constipation, and constipation can cause a lot of restlessness, a lot of pain sometimes. We have also um, Tylenol, Tylenol in different delivery systems. We have Tylenol suppositories, we have liquid Tylenol for not only for pain, but also for a little bit of the fever. Sometimes we also have medication that is called Levsin or hyoscine or atropine, that is for the secretions. So a lot of these patients are not able to swallow as well, or they're going to overproduce saliva, and that is going to accumulate here. Is going to, you're going to get wet. So we use that little medication to kind of dry them up a little bit, and drier is better. What else, Miss Isa?
um, The ipratropium. The ipratropium is medication for cough and congestion. So it'll help them open up those lungs. We deliver equipment, which we'll talk about in a little bit. But that
Yes.
medication you implement into the nebulizer, and then we put it on as a mask. And we educate the family on how to put it on as a mask, and that will be given for that cough and congestion to help that. So we have you mentioned the morphine, you mentioned the Tylenol, um, the laxative
Lorazepam.
or stool softener,
Hmm.
the lorazepam, and that as well. And again, so we're going to see the patient on what symptoms, what to expect. So these are only as needed medications. Do you have to give it? No, we don't have to give it. This is just for emergency purposes only. That way, we're able to give the medication. It's Sunday, 4 o'clock in the morning. The pharmacy is not open, and these medications require special prescriptions. And so, no, we're going to anticipate that to make sure that the patient has everything in the house that they need. And we educate the family, keep it away from children, keep it locked, keep it in a safe place. But we want it in the home to provide that symptom management.
And
Absolutely.
those are the
Yes.
most common ones. We also deal with, for other cases, we also have fentanyl, which I know has been on the news a lot. But the way we use fentanyl is number one, under the direction of our medical director with a doctor on the proper dosages. And fentanyl actually helps a lot with what is called intractable pain, pain that cannot be controlled easily. And I know that
Uh,
again. Yeah, go ahead.
we also have Zofran. Zofran for the nausea.
For nausea and vomiting.
Yeah.
Absolutely.
I have a
And
comment
these
here.
doses are low doses. We're going to start low.
Yes, absolutely. We never start on anything that's high dose. Everything is always low. Go low and slow, slow and low.
Dose. That's
We have Guillermo here all the way from Arizona. Thank you, Guillermo, for joining us all the way from Arizona. We're honored. This is a really great program, so thank you for joining us.
That's my
Um,
brother.
what else? Oh, so you're
as
the one
Ruiz,
who invited him. Okay, cool. All right. I was like, I don't think I've seen
right?
that name
he's
before.
he's a naturopath doctor in Arizona. So
Okay. Super awesome. Well,
That's nice.
good. Well, thank you for inviting him. I was like, I've
Yes.
gotten people from out of state before, but I hadn't seen his name before. Cool stuff.
Isa, you want to talk
That's
about the
why,
medical equipment?
yes,
Yes, the medical equipment. So we contract an agency that specifically deals with equipment only, and they're available 24 hours a day. So what equipment do we provide? Any, of course, routine equipment, with such as the hospital bed, the bed rails, um, the geo mattress, the alternating pressure pad that goes over the mattress as well, wheelchairs, footrest, regular footrest, elevating footrest, high back wheelchairs that recline as well, bedside tables that go with the hospital
right.
bed, nebulizers is that machine that you put the medicine in for the neb treatments for that cough and congestion, that one. Suction machine. Suction machine is in the event they have any secretions that need to be removed. We teach you how to use that suction machine. Oxygen is our main one. Oxygen tanks as well. In the event the power goes out, we need to have that backup as well. And we always teach all of our patients, in the event you use that backup, you call us immediately as soon as you're done with it, because we want to make sure that that is full and ready to go for next time in the event that we have some heavy rain and power goes out here in the RGV. So yeah, we need that, to ensure that we have enough oxygen within that home. Yes. And
Absolutely.
the shower chair, the shower
Shower
bench.
chair.
Yes, shower chair, shower bench.
Bedside
Basically,
commodes.
bedside commode, the 3-in-1 bedside commode. So there's 3-in-1. So you can put it over the toilet, you can put it by the bedside, or you can even use it within the shower to assist with that bathing. And then that way you're able to reach underneath, to provide that care on that bottom that really needs that soap and water. Absolutely.
The
And again,
Terry chairs.
all of that equipment is at no cost to the family. It's included with our services. A lot
Absolutely.
of times, families are kind of reluctant to get a hospital bed or things. But once we show them the benefits of the hospital bed, the easier to position the patient, easier to move them around. Uh, the comfort that a hospital bed can actually provide, there, it's life changing for them. And again, all of these equipments, they're on a case by case scenario. Some people might not need a wheelchair, where other people might want one, and everything is included with the program, and it's covered under the Medicare.
Yep. What about the in-home
The Hoyer
supplies
lift as well.
like diapers and the chucks pads, all of those? You want to talk about those supplies?
That's another
Yes.
thing we have.
Yes.
Yeah, we have
The
on a case by case basis. Families do get diapers, wipes, the chucks, the things that go under the bed, under the patient. Uh, we also have our CNAs. They bring in,
glove,
what's that?
Gloves.
gloves. Well, gloves. The bed pads, diapers, the wipes, the gloves, the
Wound care
skin
supplies
protectant, which is that in the event that they have wounds. Yes,
in the
absolutely.
event that they have
Colostomy
wounds.
supplies. We have the
We have
colostomy.
patients that
If
we have to drain, and we drain them at home, and we provide the equipment to do the thoracentesis, the paracentesis. Our nurses are really well trained on doing all of that. So again, that's something that instead of
Mhm.
taking the patient to the hospital, waiting a couple of hours, having it done at the hospital, and then exposing them to something that they shouldn't be exposed, bringing them back home, it's something that we actually can provide that care at home. We do it on bedside. 30 minutes later, patient is better. And those
Feels
are
more
the
comfortable.
little things that a lot of people don't we don't get to talk about, because it's not an everyday thing. Same thing with wound care.
Right.
Instead of going to the wound care center, we go and we do the wounds and take pictures, and everything is recorded, and everything is properly there. That way, when we have our meeting with the physician, if we don't like the way a wound looks, we can say, "Hey, doc, you know what? This one is doing this and it's doing that," and we get our new orders for proper treatment. So that's much better than
And,
waiting 3 or 5 days for the wound care center to report to the doctor and then getting orders back.
and we have healed
Or let missionaries know.
significant wounds, necrotic, black. I mean, severe of the severest wounds have been healed at home. So these are not small little wounds. These are entire heels, entire buttocks that have absolutely come around and closed. So this is a team that's second to none.
And we do our best. Now, we understand sometimes the diagnosis and the illness has taken its course, and the wound is not going to get any better, regardless if you reposition them every hour or give the best medication. We understand, but we're trying our best to, prevent it from getting worse, or explain to the family that this is where the disease is allowing it to go. But we will absolutely try our best.
Absolutely.
Yes.
Sure, of course, we're going to do our part as far as providers and clinicians, but obviously the patient's body has to respond. If the patient's body responds, then we have great outcomes. If they don't respond, then again, we're going to continue to evaluate, reevaluate, and make sure that the comfort is there.
Absolutely. And or we respect if they don't want it done. We're just again going to explain the benefits and the risks, and we have to
Sure.
honor the patient's wishes. Sometimes also we have, cases where family wants one thing and patient wants another. So at that moment,
So
we're going to have a family meeting and we're going to say, okay, we all need to be on the same page. And so where do we go from here? Because this is a group, this is involving family, this is involving patient, this is involving everyone. So we're all on the same page. And so we respect whatever decision they come up with, but we're giving them all the information that they can have. Ultimately, hopefully respecting the patient's wishes. Right.
And
absolutely.
ultimately,
Yes.
ultimately, that's what we want. We want to make sure that our patients' wishes are respected because that's the reason why we're there. And
Yes.
you have in hospice, you have this thing called anticipatory grieving, okay, which is something very specific. So grief and bereavement. So bereavement is the expectation of, grief is the going through. So you have the anticipatory grieving where you know that something's going to happen, you know that something's going to pass, and you're trying to get ready, trying to process. And when you go to anticipatory grieving, you do go to the grieving process. You go through the denial, the anger, the bargaining, and I tell my families it's not a straight line, it's a circle. Because you can jump from denial to bargaining back to anger, back to acceptance, back
Yes,
you go back and forth. But ultimately we're there for the patient. So there's a phrase in Spanish that says el que sufre es el que se queda, the one that suffers is the one that stays. And it's true. But we are there for the patient. So, like Ms. Isabel was saying, sometimes we have patients that say, you know what, I don't want anything done. I don't want anything done anymore. And we have to respect those wishes because our patients have rights. If they want to and they don't want to eat, they have the right not to. If they want to stay in a dilapidated home with rats all the way around and CPS, APS has been advised and everything, hey, it's their right. And we're there to respect their wishes within the safety measures and everything, making sure that everything is good. But I've had patients, I have a funny one that the patient was actually passing, and I get there, and like 6 or 7 kids were there. And, we always have this rapport with our patients, or different patients, different rapports. So I tell Mr. Patient, how you doing? And I go, anything that you want. And he goes, a beer. I'm like, okay, what kind? Bud Light, Miller. And one of the daughters' face, just like if I, said something, I'm like, look, nothing's going to happen. Let them have a beer.
yep,
So the kids went and got beers. We had the talk. I had already told them, you know what, it's going to happen soon. So 2 days later, I went to pronounce. Then 6, 8 months later, I run into them at HEB. And you know how you get those families that, hey, Sharon, Amy, go, and you don't remember. You don't remember who they are. You know that they know you. You know that you know them, but and I'm like, hi. They're like, hey, you remember me? I'm like, remind me. He goes, well, I'm so and so's son. Yes. And they go, let me show you something. And they show me a picture, and it's all of them around the hospital bed with a Bud Light in their hand.
Oh,
oh,
yes.
And I tell my families, I rather have them have that type of memory, of a good
yes,
memory, instead of a bad one. Because ultimately,
Absolutely.
the one thing that they're going to remember is not that passed on us on Easter Sunday, but that Easter Saturday we had a beer with them.
yep, yep, yep. And Guillermo has a couple of questions and comments. He says, could you discuss the misconception that hospice care is, in essence, the healthcare system giving up on the patient? So we kind of touched on this briefly at the very beginning. I think this was kind of like what we opened up with, if you will, because this really is a huge misconception in the sense that
Yeah.
once people hear hospice, they're like, it's kind of like your heart sinks to your feet and you're like, oh, there's nothing else, which is what you said, Miguel, kind of like the framing of the words when they said there's nothing else that can be done, where in reality, there's plenty that can be done. You mentioned the comfort, whether it's nausea management, pain management, making sure that the breathing is optimal. So there's so many things, but yes, even just changing that terminology uh, is extremely important. But yeah, there's so
You
many
know,
things associated. I think it has a lot to do with culture, and the issue with, death and dying. I think that I've always said that death and dying is part of once we're born, we immediately start to die. But if you sit down and you think, okay, I'm born and I'm all of a sudden dying now, then when would you start living? And so that's kind of the thing, we really shouldn't focus on that. We really should focus on living and doing great things. When people ask about my age, I'm like, I'm happy to tell you my age. It's no shame to my game. It's about all the things that you've done with your life. I can look back and say, I've done this, this, and this, uh, you know, and I'll be a million and I'll be demented by then. So I probably won't remember all the great things I've done, but I'll try to remember. But the reality is that there's just such a big, since it's the unknown, although it's a very big faith-based community, still it's just that nobody's ever gone there and come back, at least not a significant amount of people. And so the unknown is kind of scary, if you will. But I think that that's the first step is definitely education and re-education and re-education. So one of the reasons why we're
Yes.
doing this particular podcast is to give people the opportunity to hear these things from people who practice this kind of medicine. One, and two, give them the opportunity to ask questions and say, hey, I have this question, I have this doubt. From people who do this work day in and day out. He also
and
has, go ahead.
touching on that, there's a statistic from CMS that with hospice, there's a reduced hospitalization utilization of about 25 to 45%, which in the long run it benefits because we're helping and we are not taking resources from those that need it because we can treat them.
Absolutely.
And then there's a 30 to 50% lower readmission to hospitals with hospice. That again, we're not wasting those resources that can go to somebody that needs them.
We all know that there's an issue with admissions, well, not admissions, but ER visits per se, that it seems like, that's kind of like a triage center. And it's just, you know, things that should be going to urgent care or ended up in the ER, things that should be going to primary care ended up in the ER, things that should be in hospice and at home are in ER. So basically, if you have no idea what's going on and you're confused, you just go to the ER. And they're trying to set a place where people are now being sent to where they need to be. And
Yeah.
hospice can be one of those places so that they're not, at least those particular patients are being well managed. And I think it has to do with the 24-hour care, on-call care. So hospice, when you have hospice services, you have access to healthcare 24 hours. So in the middle of the night, you wake up, you don't know what's going on with the machine, you don't know what's going on with your loved one. You grab the phone and you call, and there's either going to be somebody on the phone to say, hey, this is what you can do, or there's going to be somebody to say, hey, I'm heading over right now. So you have that resource versus when you don't have any of that stuff, then you have a non-medical lay person making decisions. Well, there's no guesswork as to why everybody's ended up in the ER because they're not medical people. They have no clue as to what needs to go where. Guillermo also states, in the past, I've had family members deny this very important service because they don't want to accept the continuum of care. And again, I'm not sure if it's a lack of acceptance. It may be somewhat what Miguel stated about it could be wording. It could be a lack of knowledge as to what the services entails. And so maybe an approach may not be there's nothing we can do. But it may be, hey, you know what? I've noticed that I see that your family, that you're having to bring the patient in frequently to clinic. I think that the patient could benefit since we're having, we have long wait times in the clinic. I think the patient could benefit from staying at home, and instead of you coming to us, we go to them at home and treat these, UTIs and stuff like that. Would this be a service that maybe you're interested in? He's not really going to get, the lab draws that we're doing aren't really revealing anything that we don't know and need any aggressive treatment for. So there's no, I don't see a necessity to poke him anymore. But I do see a necessity if he has a UTI or respiratory that he gets an antibiotic. But we can go to him. Would that be a service that you may be interested in looking into? I can send somebody to your home, have them evaluate you, and then you make the decision. Like, that sounds way better than, I think there's nothing much we can do for you anymore. And, I don't think you need to come to the clinic anymore. So sometimes it's all about how you word things. And I'm not saying that you're wording things wrong, Guillermo, but, sometimes we just have to think a little bit about how we can help people get to where they need to be, like help them buy in. And if we already know it's a taboo subject, then how can we make it so that it's suitable and they at least agree to get an evaluation? We can't force them. Hospice may go over and they'll be like, no, screw you, I don't want to see you. And that's fine. We can't obligate that, but at least we've done whatever we can.
So what I would tell you
Oh,
is, I would say, you know what? Instead of thinking that it's the end of a road, it's a shift in focus. The continuum of care is about meeting you where you are. So hospice is not about stopping the care. It's about changing, instead of a curative measure, changing the goal to comfort, to dignity, to quality of life. That care doesn't stop at the patient. That care is given to the whole family. So that continuum of care continues, because we're still caring for the family. You, as a physician, you're still caring for your patient. It's just a different focus. Instead of, we're going to try and solve this issue, we know that this issue is something that cannot be solved, but it can be alleviated. So instead of focusing on chemo, focusing on, we're going to focus on making sure that they have the best life that they can have at this point. I think that will be a
and
better shift.
yes, and we've gotten those calls where I don't know if I'm ready yet. Okay, and that's okay if they're not ready, and we still allow them. Listen, if you have a question at any point in time, call us. We're here for you. Even if they're not our patient, we're just gonna, yeah, okay, tell me what's going on, and maybe we can help you. Maybe we can guide you on whatever needs to be done. We've done that before as well. So that way they feel that comfort level. And then once they've talked to, X doctor, Y doctor, and then they can have those questions because they want to hear from the doctor, which is okay. They're within their right. So that way they can ask those questions and then they get that response from the doctor, what they need to hear. Yes. Supporting them
Yep.
at any time.
Yeah, so I want to put up the information again. This is our Caring Hands Hospice and Palliative Care, and they are located, actually, I should say we are located at 3420 Carmen Avenue in Rancho Viejo. And the phone number is 956-280-5339. Guys, if you have any questions regarding hospice care, whether somebody qualifies, whether a particular benefit is that, or how you can get involved, volunteering, if you decided, what, hospice is my calling, I want to be a social worker, I want to be a chaplain, I want to be an aide, whatever it is, you know this is a phone number, this is the information, call this number so that you can get the information you need. We'll take
And you'll get a
any
human to
last
answer.
questions or comments. I'm sorry.
And you'll get a human to answer. You won't get this robocop,
Oh,
answering. No, you're going to get a human that speaks English or
yes,
Spanish, and we'll get your response immediately.
And if
absolutely, yes,
if
yes.
it's after 6, 90% of the time it'll be me.
It's, yeah, yes, it is. But
Well,
we
there
all
you go.
wrote.
You put a
And
Yes,
weekends.
and
You
And
put
he's
a
weekends.
not
face.
And weekends.
There you go.
alone. Yes, of course. We're 24 hours.
Yes. So again, if you have other questions, comments, put the last questions, comments there. If not, I'd like to hear whatever other topics, medical topics or services in the community you may be interested in discussing. If not, I'll choose another topic for next Wednesday at 8 o'clock p.m. But for those of you who are, newbies, thank you for joining us. I'd love to have you every Wednesday at 8. For the ones who are back, again, thank you for being faithful listeners and coming back every Wednesday. All right, Isabel, Miguel, you have any last words for our audience?
If you have any question, and there's no silly question at any time, you're more than welcome to call us at any time at that 956-280-5339. It's our Caring Hands Hospice and Palliative Care. So we're here for you, bilingual, en inglés y en español. Yes.
There you go. You got anything, Miguel?
Well, first of all, thank you, Sharon, for letting us be here today, for letting us join
Yes.
to share a little bit of what we do for our families, for our potential uh, patients. Just I'm glad that we explore what hospice really means. Compassion, dignity, support at the end of life. Like we said, hospice is not about giving up. It's about making the most of the time that we have, surrounded by those who care for us with comfort and care. If you're a patient, you're a caregiver, or somebody that wants to understand, we hope that our conversation that we had have brought a little clarity, a little comfort. If you guys want to talk a little bit more about this, or a little bit more in private or in person, reach out to us. We can definitely set up a family meeting, a hospice meeting. We can talk about whether we can provide that services. We can dispel any doubts that you guys have. Hospice, remember, is not the end. It's the beginning of a different type of care. That's what we want to make sure that we this hour we brought along to you guys on the audience. And again, thank you, Ms. Sharon, for letting us share.
You're
Yes.
very
Thank
welcome.
you for all you do for the patients and our families.
Absolutely.
Absolutely. And the
I'm
community, as we
honored.
see. Yes.
I'm honored. I enjoy
Enjoy.
absolutely everything that I do. Thank you for being a great boss. I wouldn't have chosen another one to
Oh,
represent our hospice community. Alrighty,
yeah.
guys. Thank you for everything. And I will, I have one last comment
Okay.
from Ida. She says, I feel blessed having a hospice team helping me out in my situation with my husband. Although it was a rough road, I had a great team that held me in one of the toughest moments of my life. So these are again always beautiful testimonies of things that people have gone through. These are the kind of things that I really enjoy seeing and hearing. It makes a big difference. I know that we can sit here and say, what a great service we provide, but when people who have actually received the service say, yes, I attest to this, this is a great service, it makes it that much more wonderful. So thank you, Ida, for providing that
Thank you, Ms.
testimony. I
Sharon.
appreciate you.
Yes. Ida brings up a good point as well, because hospice does not stop when the patient passes. Hospice continues following the patient, the caregivers, the families for 13 months afterwards or
There
more
you
if
go.
needed. So they are not
Yes.
alone. They are not
And then
alone.
every year we have our memorial service where all of our
Yes.
families come together, and we have a nice meeting, and we get to talk again with those families and those people that we saw sometimes daily, and just it's great to see that they've not moved on, because you cannot move on,
No.
but started to heal a little bit.
Yes. And we're honoring them. We're remembering them, that they are not forgotten. Yes.
It's kind of like the Dia de los Muertos kind of thing where,
Yes, very similar.
it's kind of like a
Yes.
monument, if you will.
Yes.
Right. Absolutely. That's
All righty. I
exactly.
think Miss Ida was the last comment we get. All right, guys. Good night. Thank you. And we will see you next week. So until now, have a safe
Yes.
evening and until next Wednesday. Bye
Bye,
bye.
Thank
everyone. Thank you.